Dr. Tirschwell is a board-certified neurologist. At the University of Washington, he's a professor in the Department of Neurology. And at Harvard Medical Center, Dr. Tirschwell is the neurology chief of service there. He's also the author of many publications related to stroke and on the blood supply to the brain. I'm very happy to welcome Dr. Tirschwell to our talk today. Dr. Tirschwell, take it away.
Thank you very much, Dr. Chudler. Okay, so over the next hour or so, I'm going to give you a little bit of an introduction to the topic of stroke. It's something I've spent the last 30 years of my life taking care of patients and doing research on, organizing care. So I'm, as much as I'm the chief of service for neurology, I'm really a stroke guy. Stroke neurology is what I've spent the most time on, and hopefully my enthusiasm for the topic will shine through. So this is an outline of what we'll try to cover. What is stroke? How big a problem is it? What are the risk factors for stroke? What are the symptoms of stroke and what do I do about it? And then finally, what treatments are possible for stroke in today's medical setting, and especially in a city like Seattle, where we have very sophisticated medical care. So stroke is defined by the World Health Organization as rapidly developing symptoms of brain dysfunction caused by an abnormality of blood vessels supplying the brain. And generally speaking, the symptoms have to last at least 24 hours to be called a stroke, or if they don't last that long, but there's evidence on a brain scan of a permanent injury, then that still can be called a stroke as well. So it's a clinical syndrome. You have to have clinical symptoms. A transient ischemic attack you may have heard of, it's also called a TIA, is kind of like a temporary stroke. So it's the same rapidly developing set of symptoms caused by an abnormality of a blood vessel supplying the brain. But here, the symptoms must be completely gone within 24 hours. But sometimes, even if the symptoms are gone and there's still a small permanent injury, we would still call that a small stroke. So there's a little bit of blending here that, especially with advanced imaging and our ability to detect a smaller area of injury, some things that used to be called TIAs might be called strokes. So there are three major types of stroke. And on this slide, these are images from CT scans, CAT scans, which uses, radiation and X-rays to take pictures of your brain. On the left is a normal looking CT scan, and you can see the front of the head and the back of the head are labeled. Then when we come over one, this is an ischemic stroke. As we'll see, this is the most common type where there's a blockage of a blood vessel and it causes damage to an area. It turns dark on a CT scan after a number of hours. The second most common type of stroke is called intracerebral or intraparenchymal hemorrhage, where there's bleeding, and all this bright white stuff is blood, bleeding directly into the substance of the brain itself. And then finally, an important but smaller subgroup is subarachnoid hemorrhage, where there's bleeding around the base of the brain into the tissues or the spaces surrounding the base of the brain. It's called the subarachnoid space, and thus it's subarachnoid hemorrhage. So non-hemorrhagic or ischemic stroke is caused by a blood vessel supplying the brain becoming occluded or blocked. Represents about 80+% of all strokes. There are lots of risk factors, and we'll go over some of those. High blood pressure, smoking, atrial fibrillation, diabetes. If you've had a TIA, that suggests a high risk for future stroke. And then also significant disease of the carotid artery, which is one of the big arteries supplying the brain. And here was our normal scan again, and then here was the ischemic stroke scan. And this area that I've outlined in red is the area showing the damage from that stroke. There are lots of different things that can lead to blockages of the arteries in the brain causing the stroke. And this is kind of just a graphic showing some of those causes, not necessarily all of them. A bunch of them start in the heart. So A, B, and C are all different problems with the heart. A is a PFO, which is a patent foramen ovale. It's a it's a hole that we all have in our heart where when we're in our mother's uterus, but in about 75% of the population, the PFO closes up. About 25% of us all have a patent foraminal valley still throughout our lives, which allows the possibility of a blood clot crossing from the venous side of the heart to the arterial side, rarely causing a stroke. It's most commonly thought to be related to strokes in otherwise young people who don't have traditional vascular risk factors. Heart attacks or myocardial infarctions can lead to blood clots forming in the heart that can break off and go to the brain and cause strokes. And then atrial fibrillation is a common heart rhythm abnormality that can lead to clot formation and strokes. Then we get to D, E, and F, and these are blood vessels on their way to the brain. D is the aorta, E is the carotid artery, and F is way up in the brain here, smaller arteries, all of whom can form atherosclerosis, which of course is the fatty buildup in arteries that almost everybody experiences to some degree with aging, and that can cause narrowing of the arteries and then eventually occlusion. Intracerebral or intraparenchymal hemorrhage is the second most common type. As mentioned, caused by bleeding into the substance of the brain itself, represents about 10 to 15% of all strokes. Here, high blood pressure is by far and away the major risk factor. And in this graphic, it shows some of the common parts of the brain where intracerebral hemorrhage occurs. A is sort of a cortical or lobar location for the hemorrhage, and these are actually often not due to hypertension. This is a slightly less likely area to have the hemorrhage, and this can be caused by a condition known as cerebral amyloid angiopathy, which is, again, a disease of the blood vessels in aging individuals usually, and can cause these superficial brain hemorrhages. And then B, C, D, and E are 4 common locations in the brain where high blood pressure related hemorrhages do occur. Here's our normal scan again. Then here's this big hemorrhage into the brain. This is one of the deep areas, so this is more likely a hypertension related hemorrhage. And then finally, subarachnoid hemorrhage caused by bleeding into the membrane surrounding the brain, only about 5% of all strokes, and an aneurysm in those blood vessels towards the base of the brain. That's the most common cause. And it's the only of the main types of stroke that's more common in women than it is in men. Here's our normal scan, and then here's the scan with the subarachnoid blood in the areas surrounding the base of the brain. And then here's a really cool kind of cartoon drawing by Frank Netter, who is a really famous medical illustrator and has published many books of illustrations. And this shows the common areas where aneurysms can occur in the blood vessels at the base of the brain. This is the looking up from the bottom of the brain. This is what's called the brain stem back here. And then these are, you can see these little bubbles on all the arteries are the places where the aneurysms can occur. The anterior circulation, which is the part that supplies the big top parts of the brain and comes from the carotid arteries, about 85% of the time the aneurysms in the anterior circulation, and then the posterior circulation down here that supplies the brain stem, about 15% of the aneurysms. Nobody, I don't think, has ever been unlucky enough to have an aneurysm in all these different places at the same time, thank goodness. So this is a graphic actually based on some old data from Washington State, but it's pretty typical in most population. It shows the breakdown of the different stroke types from hospital discharges, and you can see far and away ischemic stroke due to a blockage of a blood vessel, the vast majority of all strokes discharged from the hospital. Intracerebral hemorrhage, second most common at around 10 or 11%, and then the subarachnoid hemorrhages at around 5%. Now, I work at Harborview, and we get a lot of transfers of very sick stroke patients into our stroke center. And because the hemorrhagic types of strokes are often more serious, our stroke population has a relative overrepresentation of the hemorrhage type. So For us, instead of 80%, ischemic is only just over half of the strokes that we take care of. Intracerebral or intraparenchymal hemorrhages are almost a third. And then the subarachnoid hemorrhages in our stroke center are around 15%. So that's a little bit about what is a stroke, but how big a problem is stroke? That's our next question. Well, here's a graphic from the World Stroke Organization, and it has some key facts in it. 101 million people on the planet are living with a stroke and its aftermath at this time. Each year, there's 12.2 new strokes throughout the world. 90% of all strokes are linked to 10 modifiable risk factors and a few non-modifiable risk factors. And we'll talk about many of those during this hour. There are 143 million healthy years of life lost to stroke each year. So that's a statistic that sort of looks at how many people are having strokes and what age they are when they have strokes. And they kind of predict how much healthy years they've lost because they've had their strokes. And then this, I think, is really startling. 1 in 4 people over age 25 will experience a stroke in their lifetime. So it's very common over the course of the life, and we should all try very hard to avoid it. This is data that comes from a research group called the Institute for Health Metrics and Evaluation, IHME. It's a University of Washington based, though globally impacting health evaluation project. And they look at causes of death and other causes of illness and measures of the impact of those causes around the world. And over time. And I just include this graphic just to show you that in 1990, stroke was the second leading cause of death. And it's really, even in 2021, it's still right at the top. It's only moved out of the second spot because in 2021, of course, we're in the midst of the pandemic and COVID-19 overtook it. I don't think they've published any more recent data, so I can't say whether it's moved back into second position, but I expect it very well might as the pandemic hopefully continues to die down. This is a different sort of graphic that looks at the different causes of death in some of the big countries around the world. Here on the vertical axis, you can see the different causes of death, and then there's different countries here on the horizontal axis, and they got China in the first place here because it's one of the biggest countries, and stroke is, and these are 2021 data, stroke is the #1 leading cause of death in China. In Indonesia, it's also #1. In Japan and Ghana, it's #2. A whole bunch of countries, it's #3. And then here's the United States down here, where stroke is the 5th leading cause of death in 2021, ischemic heart disease being #1, and #2 doesn't seem to have made this particular list. So just an interesting set of different comparisons. And although stroke is important almost everywhere across the world, there is some variation depending on which country you're in. And then coming down a little bit closer to home, this is a map of age-adjusted death rates across the United States. And of course, we're all getting used to looking at maps like this with either blue or red colored states as we get closer to the election. But here, it's all just about how dark a color it is. The darker colors have higher stroke rates. And you can see that in the Southeast, an area of the country that has often been called the stroke belt, there's some of the highest rates of stroke death in the country. Here we are up in Washington, sort of the second lightest color, not in the best category, but certainly not in the worst category, which is this darker blue. And then drilling down even further, here's some stats from Washington State. It's a few years old. Got these from the American Heart Association. Stroke was the 6th leading cause of death in Washington State at just over 5% of all deaths. And in 2017, over 3,000 people, that 5.3% correlates to over 3,000 people in Washington State dying of stroke every year. So it is a big public health problem. All right. So what is stroke? How big a problem? We just answered that. What are the risk factors for stroke? So here's a case. We'll put this in a little bit of context. I see a 70-year-old patient with high blood pressure, but without any history of cerebrovascular disease, that's stroke. And actually, it's more likely that a primary care doctor is seeing this patient, not me as a stroke specialist. But they walk into their primary care doctor's office saying that their friend just had a stroke, and they want to know what they can do to decrease their risk of stroke. And so there are some non-modifiable risk factors for stroke. For example, age. As much as we'd all like to be able to dial back on our age, we cannot do so. And so that is an important risk factor for stroke. Gender, in general, men are at higher risk of stroke than women are. Hereditary, so there are a number of genetic conditions, some that relate to risk of atherosclerosis that also correlate with risk of stroke. Race and ethnicity has been associated with stroke rates. Many underrepresented groups have higher stroke rates. In part, it may be genetic. In part, it may be decreased access to medical care. There is this observation that although still rare, the peripartum and postpartum period is a time of high risk for women and their chances of having a stroke. And then finally, migraine is a condition where there is an increased risk of stroke, especially severe migraines with aura can slightly increase the risk of stroke. All right. And then there are a bunch of modifiable risk factors, and we'll go through each of these one at a time, so I won't pause here for too long. Here are some lifestyle factors that can affect your risk of stroke that you have some control over. So avoiding tobacco and especially cigarette smoking would reduce your risk of future stroke. Eating a healthy diet, and of course, we know that definition of what a healthy diet is seems to modify over the years, but generally speaking, lots of fruits and vegetables and fresh food and avoiding highly processed, sugary and fatty foods. Those are the general rules of thumb that seem to consistently hold. Lots of physical activity is good for you in so many ways. Having an appropriate body weight, not drinking too much alcohol, so less than or equal to 1 to 2 drinks per day. There's actually some evidence that occasional alcohol might reduce your risk of heart attack and stroke. And then no drugs of abuse, and especially cocaine, methamphetamine, and heroin have all been associated with increased risk of stroke, pretty convincingly. So high blood pressure is probably the number one risk factor for stroke. And some people have estimated that if we could somehow magically make high blood pressure disappear, the result would be that half of all strokes would disappear as well. So if you have high blood pressure, make sure you treat it. You'll be doing something very important for your health. And what this graphic shows is that just with the usual mean diastolic blood pressure, the risk of stroke goes up steadily. So as blood pressure goes up, the relative risk of stroke goes up and up as well. Very, very important. It's a major modifiable risk factor, overall doubles your risk, and there's this dose-response effect that I was just describing, and it may cause half of all strokes. If we treat blood pressure, you can reduce your risk at least 40%. This is a definition of high blood pressure from the National Institute of Health, Institute for Heart Disease and Blood. Common disease, talks about the force of the blood pushing against the walls of the artery as the heart pumps the blood. And there's, when you measure your blood pressure, you get a top number and a bottom number, the systolic and the diastolic pressure. The top number, the systolic, is the blood pressure when the heart beats while pumping the blood, and the diastolic is the pressure when the heart is at rest between beats. And that's why you get those two values. They're both important to follow and keep within a healthy range. This is another informational page from the National Institute of Health, and it talks about the treatment of high blood pressure. And again, lifestyle issues come in here, things that we can control. So just in this area here, healthy diet, reducing salt and sodium, healthy weight, physical activity, limiting alcohol, not smoking. And then there's a bunch of medications. If despite your best efforts, your pressure is still up, there are lots of medications to help treat blood pressure. Atrial fibrillation is another major factor and also strongly related to age. It's an irregular beating of the heart, which can lead to clot formation. Those clots can break off, go north up into the brain, and cause strokes. It's found overall in about every 5 ischemic strokes with a relative risk. So if you have atrial fibrillation, you're at about a 5 times increased risk of having a stroke. Over their lifetime, about 1 out of every 3 patients with atrial fibrillation will have a stroke. The overall risk is about 5% per year. In the rare case where you're young and you don't have other vascular risk factors, your stroke rate might not be as high, but that's rare. And if you've already had one stroke and you have atrial fibrillation, the risk of another stroke is extremely high, left untreated, up to 12% per year. But strong blood thinners like warfarin reduce that risk by over 2/3. Aspirin does a little bit. And then there are newer blood thinners that are probably safer than warfarin. It might actually even be a little bit more effective than the warfarin in reducing the risk of atrial fibrillation-related stroke. And those have become the new standard of care for stroke prevention in atrial fibrillation. This is a nice graphic which just shows the relationship between age here on the horizontal axis and the proportion of stroke patients that have atrial fibrillation. So when you're young, a stroke at less than 60 years of age, it's only about 5% of stroke patients that have atrial fibrillation. And by the time you get to 85 or more, it's almost 40% of stroke patients that have atrial fibrillation. All right, well, what about cholesterol and diabetes? High cholesterol has been shown to increase the risk of ischemic stroke, the blockage type. And statins, which are a very commonly used cholesterol medication, lower the risk of that type of stroke. There have been a number of observations which have also showed that very, very low cholesterol levels may increase the risk of the hemorrhagic types of stroke. So sometimes if somebody has a history of a bleeding stroke, we may not push their cholesterol quite as low. And then diabetes clearly increases the risk of ischemic stroke due to those blockages, often because it accelerates atherosclerosis and the narrowing of the arteries. And good blood pressure control from the diabetes can reduce this risk. So very important. Well, what about the carotid arteries? The carotid arteries, here we can see the right carotid artery is this big blood vessel that supplies much of the anterior part of the brain. It's a paired structure, so there's one on each side, and together they supply the blood to much of the brain. Just for a little bit of orientation, you can see here the jaw, and this is the brain stem, the bottom of the brain, which is largely supplied by this posterior circulation. These carotids are called the anterior circulation, and here's the aorta, and the heart would be just below this picture if we were able to see it. So we measure the narrowing in a carotid artery. We call it the percent stenosis. And here's the formula that's generally used. The area above the stenosis where the artery is sort of returns to a normal steady diameter minus the narrowest portion divided by the normal portion. And just as an example, here's an artery, here's the internal carotid artery. We can see this area of clear narrowing or stenosis. And this is a big time risk factor for stroke. So we like to know about these things, especially if you've had a recent stroke or TIA, you need to get this sucker fixed. In this particular case, we put some calipers on it to measure it. And we've got these units that it doesn't really matter what the units are because it's all just about a proportion. So we do our little equation, A minus B over A. And here this comes out to about a 75% stenosis. That's considered a high-grade carotid stenosis. And what are the treatments out there for carotid stenosis? Well, if we find a significant narrowing, but you haven't had symptoms, the benefit of surgery isn't quite as clear. We would aggressively treat risk factors, but with very careful patient selection because the benefit isn't quite as clear. On the other hand, if it's been symptomatic, you've had a recent stroke or TIA related to that carotid artery, there's a large benefit from surgery if your narrowing is greater than 70%, and our patient here in this example was 75%. So in those cases, we would do either stenting, which is sort of a inside the vessel opening of the artery, versus an open surgical procedure called carotid endarterectomy to try to get that vessel back open again. There are also medications that affect the risk of stroke. Aspirin may decrease the risk of a first stroke in women only, and may very slightly increase the risk of a bleeding type of stroke, but also it's an important part of prevention of second stroke. So most patients who have already had one ischemic stroke will end up on aspirin or a similar blood thinner. Warfarin, which is a stronger blood thinner, or these newer direct oral anticoagulants are very important for decreasing the risk of stroke in patients with atrial fibrillation and rare other causes. Attention deficit disorder medications, which are all stimulants, or many of them are stimulant-type medications, have been associated with a small increased risk of stroke. And while we don't prevent people from taking that if they've not had a stroke, if you've already had a stroke, we'll often recommend that people consider stopping this type of medication to increase their risk of a subsequent stroke. Oral contraceptive or birth control pills in the past had been associated with a risk of stroke, but with newer, lower dose and progesterone largely only agents, that's less of an issue. And then hormone replacement therapy in postmenopausal women was associated with a small increased risk of stroke, but sometimes the hormone replacement therapy has big benefits on quality of life, and so that's an individualized decision that people make. So here's our second case, a 70-year-old patient with high blood pressure and diabetes who presents to an emergency department after a 30-minute episode of right-sided weakness and trouble speaking. Their blood pressure on initial evaluation was 158/94. That's elevated. What is their risk of stroke? And remember, we talked about TIA. That's a transient ischemic attack, essentially a temporary stroke. The short-term risk of stroke can be quite high. So stroke event rates can be up to 5% in the next 2 days and 10% by 90 days. So, and you're especially at increased risk if you're older than 60 years of age, if you had weakness as one of the symptoms with your TIA, if you also have diabetes, if your TIA lasted longer than 10 minutes, and if you had speech impairment with your TIA. And as a result, you should seek medical attention promptly. Having had a TIA is a clear need for a prompt workup, and that workup should generally be done immediately. If you think you've had a TIA, completely appropriate to go to an emergency room for an evaluation, or if you can get into your doctor the same day, that may be okay, but they might not be able to do as many tests as quickly as in the emergency department. Especially if your TIA is recent, you should take quick action because of that high early risk of recurrent stroke. In our care system, in the UW system, we'll offer a brief admission to the hospital in most cases to get that workup done as quickly as possible. And that workup usually includes things like brain imaging, imaging of the blood vessels supplying the brain to see if there's any major blockages, heart imaging and heart rhythm monitoring to make sure you don't have atrial fibrillation. Maybe you need one of those strong blood thinners. And then we're treating with different sorts of blood thinners, maybe carotid surgery, treating these other risk factors, hypertension, diabetes, cholesterol, all in an attempt to reduce your risk of having that next stroke. So, okay, we just talked about what are the risk factors for stroke. So now what are the symptoms and what do I do if I think I'm having a stroke? So this graphic is a nice one. It comes from the National Stroke Association, and it just shows, sort of gets the idea across that different parts of the brain have different functions. And so, for example, the front part of the brain, and this shows the left part of the brain. So as you'll see on the next slide, that controls mostly the right side of the body. Motor functions are more likely controlled in the front of the brain. Sensory functions more towards the back of the brain. There's a speech area here, usually on the left side towards the front. There's a hearing and language understanding area a little bit further to the back. Vision is way in the back of the brains. Emotions can sometimes be up here. And so depending on where your stroke is, which areas of the brain it's hitting, the symptoms can vary quite a bit. And that makes it hard sometimes to identify a stroke. This is an interesting and neat little graphic that shows some of the functions on the different sides of the brain. And you can see here's the left side of the brain, which you can see controls the right hand. So the left, I'm having trouble with the colors a little bit here. This left side of the brain controls the right hand, and is especially important in language function, numbers, reasoning, and scientific functions. The right side of the brain over here controls the left side of the body and is more concerned with creativity, insight, spatial orientation, and music. And of course, these are generalizations. And to some degree, if you're a lefty, sometimes some of these things flip back and forth. So there's lots of interesting stuff going on here. And again, depending on where your stroke is, your symptoms can vary quite a bit. I'm not sure what that little thing was supposed to do. Sorry about that. So these were some of the common symptoms of stroke that the American Heart and Stroke Association has been advertising for many years. Sudden numbness or weakness of the face, arm, and leg, especially on one side of the body. And I would say that that is the classic stroke symptom and the one that most commonly people will recognize as a stroke. And these other ones can be a little bit more unclear. So sudden confusion or trouble speaking or understanding, that can happen without weakness and sometimes is harder to identify as a stroke. Sudden trouble seeing in one or both eyes. That can be a stroke also, a stroke in the eye itself or a stroke in the back of the brain where the vision centers are that can cause you to have an alteration of the vision. Sudden trouble walking, dizziness, loss of balance or coordination. There's a structure in the back of the brain called the cerebellum, which is vulnerable to having strokes. And sometimes a stroke there will just cause sudden severe dizziness, vertigo, and falling down because you're so off balance. So that can be a sign of stroke. And then sudden severe headache with no known cause. That's more common in the hemorrhagic varieties of stroke. But nonetheless, especially if it's the quote unquote worst headache of your life, you've never felt any pain like this, those are red flags for a headache possibly being a sign of a stroke. These symptoms have been sort of propagandized into this mnemonic called Be Fast. It helps you remember some of the symptoms for stroke. And this is the Harborview and UW Medicine version of the Be Fast algorithm. They've been carefully multiculturalized as is appropriate. And then this is how you remember the different symptoms. B is for balance or sudden loss of coordination. E is for the eyes or vision changes. F is for face, drooping or unevenness. Arm is weakness in the arm or leg on one side of the body. Speech is a speaking difficulty or trouble understanding. And then T is for terrible headache. And, the T at times in the past stood for time to call 911, which is a little bit lost in this message, but that is the message that should be going out to the public. If you notice any of these symptoms, that's what you should be doing. you should be picking up the phone, or somebody near you should be picking up the phone and calling 911. So this is how one graphic of how to think about the care continuum for stroke, and it starts in the pre-hospital setting where we're trying to promote public prevention messages and improve EMS care and transitions, but also public knowledge about the signs and symptoms of stroke, so that if you are noticing something like that in yourself or somebody that you're with, you can call 911, and then EMS comes to the scene. EMS actually has algorithms for stroke care, and depending where you are and what the nearest hospital is and what their particular capabilities are for stroke care, they might take you to the nearest hospital. They might take you to a place that's a little bit farther away that has more resources. You get emergency care on the inpatient setting, and then hopefully you're surviving your stroke, and we're working on discharge, trying to help facilitate recovery and get you back out in your community, with your loved ones, to continue your life. And I'm just going to spend a little bit about some of these stroke care aspects. There are actually 4 different levels of stroke centers that are described, at least in the United States today. They go from sort of the least resource-rich acute stroke-ready hospitals to the most resource-rich comprehensive stroke centers. Harborview in Seattle is the comprehensive stroke center in the UW-Medicine stroke system, but there are other comprehensive stroke centers in Seattle and in other areas around the state. Thrombectomy-capable stroke centers don't have quite the resources and might have to even transfer their most severe strokes to a comprehensive stroke center. And then primary stroke centers can take care of lots of strokes, not all of them, especially the more severe ones. And acute stroke-ready hospitals generally can triage patients in their emergency departments, but will often end up transferring stroke patients to one of these higher level stroke centers. So that's what you do. You know the symptoms now, and to call 911. What treatments are possible for stroke? Well, here's the acute stroke treatment algorithm that the physicians at Harborview and UW-Medicine-wide kind of have internalized over the years. It's pretty complicated. There will not be a quiz on this later. I will say that I've simplified some of the ideas here. So first, in the emergency department, your providers are getting a short history and physical exam, a quick blood draw, and then taking you straight to the CT scan. Because as you saw on those CT scans, it's often pretty easy to tell early on if there's blood because it's so bright white on those scans. And that takes you down a very different treatment algorithm than it does if there is no blood and you're presuming a blockage of an artery that you may try to get open. So we're going straight to the CT scan. Then there's either blood or no blood on that first CT scan. If there is blood on that scan, well, then some of the things that we look at is if you were on blood thinners, that may be exacerbating your continued bleeding in your head, and we want to reverse any blood thinners. We're usually lowering blood pressure because it's often very high when you've had an intracranial hemorrhage like that. We're considering whether surgery might be needed to be a life-saving procedure, and we're often admitting these patients to an intensive care unit, and at least in our stroke center at Harborview, it's a neurologically focused intensive care unit where you can get expert care by people who have a lot of experience taking care of stroke patients. Well, what if there's no blood on the scan? That's a little different. And if you arrive at the hospital early enough, you might be able to get an intravenous clot-busting medication. So you've got this blocked artery, and if you get that clot-busting medication early enough, that medication alone, which actually can be given in all of those different levels of stroke centers because it's a simple IV medication, that might be able to get your blocked vessel open and help improve the outcome from your stroke. Doesn't always work, but if we treat 100 people with and 100 people without, the 100 people with are going to have more good outcomes than the 100 people without. Then, if one of the larger vessels supplying the brain is occluded, we now have lots of evidence suggesting that it's possible to remove that clot mechanically. My colleagues will go in through catheters, through the big arteries, and snake their way with their catheters all the way up to the brain, where they literally snatch the blood clot out of that big vessel, pull it out of your body, opening your blood vessel up again. And if we can get that done fast enough, we can also really improve outcomes from stroke. If neither of those happen, or either in cases where it does happen, we're looking at blood thinners long term. We're very careful and intentional about blood pressure management in the acute stroke setting. And then all stroke patients are admitted to the hospital with standard orders for consistent care. We determine the cause of their stroke as best we can, which allows to a personalized plan for preventing future vascular events, including recurrent strokes. And then we're also very early getting physical, occupational, and speech therapies involved with our stroke patients to try to optimize their outcomes. Now, lots of things can happen and are common after strokes. And I'm just going to very briefly go through this. I could spend a whole hour talking about this one slide, but physical or functional disability is present in almost half of all patients that have had stroke. Fatigue is very common, half of all stroke patients. Sleep disorders, half of all stroke patients. Multimorbidity, so most of our stroke patients have these other vascular risk factors or chronic medical conditions that we also have to treat and get under control, both for their general health and also to reduce their risk of future strokes. Apathy and mental illness is also very common. Apathy, anxiety, and depression, very common after stroke. And then there's also post-stroke cognitive impairment, which is quite prevalent, including the possibility of post-stroke dementia. And this is one graphic that just talks about cognitive impairment and dementia that can occur after stroke. So we have a lifetime of environmental exposures and vascular risk and socio-demographic factors that combines with genetic susceptibility to put your brain in a state that progresses throughout your life. And you may have already had some more microscopic or non-vascular related injuries to your brain before you have a stroke. And how much of this pre-existing pathology you may have can inform how much vascular reserve or cerebral reserve that you have. And then when you have a stroke, as you know now, we're damaging part of the brain, and it's a permanent injury, a stroke is, to the brain. And so, your cerebral reserve goes down, and depending on where your stroke is, your symptoms can vary quite a bit. And despite acute treatments and rehabilitation, there's often still post-stroke cognitive and functional declines. There are some mechanisms of brain resilience that are kind of built in that help us all try to recover. But it is a really complex web of processes that occurs after a stroke. And we try to work with all of our caregivers and our patients to optimize outcomes. And I just want to leave you with this. This is an American Heart and Stroke Association campaign called Life's Essential 8. And it gives you 8 things that you can all work on in your lives to reduce your risk of not just stroke, but also heart attack. And there's some evidence to suggest that doing well in all these areas may actually decrease your risk of dementia as well. So have a look, healthy diet, more physical activity, good blood sugar control, a healthy weight, healthy cholesterol, good blood pressure, not smoking or vaping, and adequate sleep. Everybody deals with these decisions on a nearly daily basis, and you can make a big difference in your risk if you aggressively manage them all. And so that's it for me on the fixed part of this thing. Stroke is an emergency. The sooner you get treatment, the better your chances of a good outcome. So time is brain is something we like to say. You should act fast and call 911. And thank you all for your attention.
Thank you very much, Dr. Tirschwell. There are a couple questions in the chat, and actually, a couple of the questions came in, and you've answered those as well. But I want to get to some of those. The
Sure.
first question that someone has is that you mentioned some of the risk factors, specifically about particular drugs, mentioning some of the amphetamines and heroin as being risk factors. But what about marijuana? Is marijuana on the list as well?
Yeah, that is a great question, and there's a little bit more debate about that. Um, there is a rare constrictive syndrome of blood vessels that can cause stroke called reversible cerebro reversible cerebrovascular vasoconstrictive syndrome (RCVS) that has been associated with marijuana use that can sometimes cause stroke in young people. It's my impression of the literature that a lot of marijuana smoking, especially, can increase the risk of stroke. I think there's some preliminary suggestions that edible forms of marijuana might not carry quite as much risk. And of course, we are now in an environment where marijuana is legalized in many states across the nation. And so these are really important topics. So thank you for that question.
Yeah, and another question, and you presented this on one of your later slides, is a healthy blood pressure. You mentioned 120/80. Is that still the recommended numbers for a healthy blood pressure?
Yes,
Okay.
120/80 or less.
And you also mentioned on one of your slides toward the end is how an existing condition, for example, Alzheimer's, might interact with stroke. Can you tell us a little bit more about that?
Well, so let's say you have developed even just the beginnings of Alzheimer's disease and you're starting to have trouble with memory and or speech, let's say, and then on top of that, you have a stroke. This idea that you come to your stroke with a certain amount of brain function. If you have that mild Alzheimer's disease, for example, your overall cognitive status that you're coming to the stroke with is already reduced, and then the stroke is sort of a second hit on top of that, and so it can really amplify the stroke can really amplify some of the cognitive effects of the Alzheimer's. And it can happen in the other order as well. A stroke can happen first. And then if you start to have some Alzheimer's pathology in your brain, it can really go faster or be amplified by a subsequent, by the previous stroke and things like that. So in many ways, obviously the brain is an organ, and all of the different unfortunate ways that nature has devised to hurt our brains will interact and sort of summate to your sort of current cognitive status. Stroke can injure it. Pre-existing things like dementia can also injure it.
Yeah, thank you. And you mentioned the acronym Be Fast. The T of fast means terrible headache. How can you tell the difference between a migraine and a stroke event? Or there's something else that differentiates the two?
Well, um, yes. So migraines are usually a chronic condition that you've had over many years of your life. Often it starts at younger ages when the suspicion of a stroke is less likely. So if you've had migraines your whole life and you're having a headache that is similar to your previous migraines, well, then you can make pretty confidently the identification that that's probably not a stroke, that's a migraine because it's your typical headache. But if you have no history of migraines and you're later in life and you have the sudden onset of just a horrible headache like you've never had before, it really sticks out as a different kind of event. That's the kind of headache that you want to worry about might be related to a stroke.
Yeah, certainly makes sense. Yes. You also mentioned some of the drugs that are available to break up those clots. Is there a window that where they become more effective? And it appears that one of our listeners, one of our viewer, is familiar with some of these new anticoagulants. Do you have any comments on that? So again, the window for when these can be used, And is there anything new coming down the line?
Yeah. So the window, as it stands right now, is largely less than 4.5 hours. And that's when the treatment has to be given. And it has to be, there's a lot of rules around this. And so we don't get to do it that often, but it has to be within 4.5 hours of you last known to be normal. So if you wake up with your stroke in the morning and you were asleep 8 hours, you're probably not going to be able to get that clot buster medication. And in fact, we have to do some tests at the hospital that take time. So you really have to get to the hospital within 3.5 hours, I'd say, so that we can do some tests and make sure it's not a bleeding type of stroke before we give you this type of clot buster to try to open up your artery. And, we did nationally, and now I would say globally, there's a transition from one type of clot buster to what's really kind of a close cousin medication that maybe is a tiny little bit better, but still has the same time window. And then there are rare circumstances where we can extend that time window, and there is research ongoing looking to extend that possible time window, hopefully with safer drugs, so that more people can get that relatively simple treatment. And then as far as other newer blood thinners, a lot of what I was talking about was for chronic stroke prevention. There are new oral blood thinners to prevent strokes. Those are less related to trying to break up a clot during an acute stroke.
I have one of my own follow-up questions to this line, and that is, how would the decision be made about whether to actually do the surgery you mentioned, you're actually reaching in there and physically pulling out a clot versus giving one of these drugs to break up the clot?
You can get both. And in fact, if you get to the hospital early enough, you might get the intravenous clot busting medication. And then if we also identify that one of your larger vessels is occluded, we're not going to wait around and see if that medication works. We're going to let it start doing its business. And in the meantime, we're going to wheel you down as quick as we can to the procedure suite, where my colleagues will then try to get their catheters in and up to the clot as quickly as possible and pull that one out. Now, just like for the clot busting medication, there's a whole bunch of inclusion criteria that you have to meet to qualify for the interventions. We don't get to do it for everyone. And as is the case with many medical procedures, there's no guarantee of success. Sometimes even we go in there, we get the clot out really quick, but it turns out that even when we do it quickly, sometimes it's been too long and the brain has been irreversibly damaged and a significant stroke still results. But just like I described earlier, if we had 100 patients who were able to pull those clots out from and 100 who we didn't pull the clots out from, there are definitely going to be more good outcomes in the patients that we took the clots out from. We just can't guarantee that every time.
Another question had to do with post-stroke conditions and how likely or how long will these occur after a stroke happens?
Many of them occur right away. Some of them can occur in a delayed fashion, and some, I would say, frankly, aren't noticed until a little bit of time passes, because perhaps you have to recover a little bit before you can really appreciate that there's depression or new anxiety going on post a stroke. So there's quite a bit of variability there, I would say.
And perhaps the last question we'll have is, two people have a question about who to see after a stroke. For example, if they're not near the UW, should they go to the regular hospital? What procedure should they follow?
To to a little extent, it depends on what type of stroke. Subarachnoid hemorrhages are often followed up with neurosurgeons and rehab docs. For the vast majority of strokes, especially those due to blockages and things like that, following up with a specialist like myself, a stroke neurologist, is a good way to go. If you don't live near the UW these days, especially if you're in Washington State, you can actually do video visits that are pretty darn good. You just got to get a referral. And if that's not working out for you, you prefer to see people live, which is something some older patients like. Um, then I would say locally, neurologists in general, they don't necessarily have to have specialized in stroke. They'll still have lots of experience taking care of stroke patients. They would be maybe the second best category. And then if there's no neurologists around, well, then, your primary care doc is a good place to start, and they might be able to get advice from colleagues if there are complicated care issues.